Welcome to this explainer. So you're gearing up to step into the shoes of a public health detective, or maybe you're just looking to completely ace your upcoming epidemiology exam. Either way, you are in exactly the right place. We're going to take all that dense textbook knowledge, cut through the jargon, and make it conceptually crystal clear so you can actually track down diseases in the real world. Let's get into it. Here's our roadmap for today. We'll quickly cover epidemiology, core concepts, learn to measure morbidity and mortality, dive into a real-world case study on the opioid epidemic, map out disease causality, look at surveillance and screening data, and finally, break down the levels of disease prevention. All right, let's kick things off with Section 1, Epidemiology, Core Concepts, the Detective's Foundation. To solve any case, we really need to understand what we're investigating. When epidemiology pops up on your test, you've got to remember the big split. Descriptive epidemiology is all about drawing the map, the where and the who of disease distribution. Analytic epidemiology, on the other hand, is the deep dive into the why and how, looking at the actual determinants and root causes. Keep those two approaches completely distinct in your mind. Moving right along to Section 2, Measuring Morbidity and Mortality, basically the math of disease. Okay, grab your mental highlighters for this one. Both of these concepts deal with new cases, but they are absolutely not the same thing. Incidence proportion is your general measure of new cases over time for a whole population. But the attack rate, that is highly specific to a group that was exposed during an outbreak, like, say, everyone who ate the exact same questionable potato salad at a summer picnic. Identifying that specific exposure element is a massive differentiator for your exam. Next up, we have the case fatality rate, or CFR. This one is pretty heavy, but it's a critical mortality measure. It literally tells us if someone gets this specific disease, how lethal is it? Notice that we aren't looking at the whole population here. We're isolating just the group of people already diagnosed with the disorder, and then calculating the proportion of those who, unfortunately, pass away from it. Now, I guarantee you're going to see this next concept on your test: incidence versus prevalence. It all comes down to the keywords. Always look for the word new for incidence and existing for prevalence. Think of it like a bathtub. Incidence is the new water flowing out of the faucet into the tub. Prevalence is the total amount of water just sitting there in the tub right now, combining all the old water with the new. Let's put this math into practice with Section 3, a case study on the opioid epidemic. So, how do public health officials actually use these rates in the real world? They certainly aren't just guessing. When we're up against a crisis that tragically claims nearly 100,000 lives a year, we have to track the exact statistics on overdose mortality rates over the past 5 years. We desperately need to know if the incidence of opioid use disorder is climbing, and exactly what the case fatality rate of an overdose looks like across different communities. When we track those overdose mortality trends over time, we're looking for patterns in the descriptive epidemiology. Are there point epidemics, sudden, terrifying spikes in a specific town? Or are we seeing secular trends, which are those slow, long-term changes spanning years or even decades? Recognizing these patterns is absolutely crucial because it tells us if the epidemic is getting worse or if our interventions are finally starting to stabilize things. If you want to think like a true medical detective, you need a system to process all this surveillance data. By systematically asking the 5 W's, who, what, where, when, and why, you literally cover every single base. You move seamlessly from the basic descriptive tracking of a disease right into the analytic causality of why it's happening. Which leads us perfectly into Section 4, Mapping Disease Causality. This is all about finding that why. Because here's the thing, diseases, especially complex chronic ones like addiction or heart disease, they don't just happen in a simple straight line. Instead, they're the result of a massive web of causality. We're talking phenotypes, social structures, behaviors, genetics, and environments all interacting. When you view the opioid epidemic through this web, it suddenly makes sense how economic distress, historical prescribing practices, and individual human biology all tangle together to create the crisis. Zooming out even further, we get the ecologic model. Think of this like a set of nesting dolls. It starts right in the center with a person's innate traits, stuff like age and sex. Then it expands outward to their individual behavior, then out to their social and family networks, and finally all the way out to broad, global, and environmental living conditions. It's a great reminder that to effectively treat a patient, we often have to treat their environment first. Now let's pivot slightly to infectious diseases. For your exam, you absolutely have to know the epidemiologic triangle. Whether it's MRSA, COVID, or tuberculosis, you map the outbreak using 3 points: the infectious agent, the host's immunity, and the environmental mode of transmission. If you can understand how those three connect, you can figure out exactly where to break the triangle and stop the disease in its tracks. All right, Section 5, surveillance and screening data, basically how we gather our clues. Active versus passive surveillance. This is another major high-yield topic for you. The entire difference comes down to who initiates the data collection. Active means public health nurses are pounding the pavement, proactively hunting down data during an active outbreak. Passive means the system is just waiting, relying on local clinics and providers to routinely send in their standard reports. Make sure you know the difference. Once we know what we're looking for, we often need to screen populations. When we screen, we're testing groups of asymptomatic people to find those at risk before the condition fully develops. Notice the keyword there, asymptomatic. If a patient already has symptoms, you're doing diagnostic testing. Screening is entirely about catching things early in seemingly healthy people. Okay, pay close attention because this trips everyone up on the exam. Sensitivity versus specificity. How valid is our screening test? Remember this simple rule of thumb. Sensitivity catches the sick. It gives you your true positives. Specificity clears the healthy. It gives you your true negatives. A highly sensitive test won't miss many sick people, and a highly specific test won't falsely alarm a bunch of healthy people. Have you ever wondered how one single case at a small local clinic ends up in a massive national surveillance database? It's a very specific pipeline. It starts with a mandated report at the state level. Then, states voluntarily share that data with the CDC's National Notifiable Diseases Surveillance System, and eventually it gets published in the Weekly Morbidity and Mortality Weekly Report. It's the ultimate flow of epidemiological data. All right, final stretch. Section 6, Levels of Disease Prevention, where we finally take action. This right here, the prevention pyramid, is literally your cheat sheet for public health interventions. You've got to know this inside and out. Notice how it moves from the super broad base of the completely well population at the bottom all the way up to the narrow tip of people who are already dealing with established health problems. Let's break those steps down really quick. Primary prevention stops the disease before it ever even starts. Think immunizations. Secondary prevention is all about early detection. This is exactly where your screening comes in. And tertiary prevention focuses on managing the disease once someone already has it, like rehab for a stroke patient. Whether you're fighting an infectious bug or tackling the opioid crisis, you'll need to accurately categorize your interventions into one of these three steps. So we've gone through the math, the models, the surveillance, and the prevention strategies. But here's the real question as you head into your exam and your future career. How will you use these powerful epidemiological tools, not just to study disease, but to actively advocate for policies that prevent it in your community? Think about it. Thanks for joining me on this explainer, and good luck out there.